Hello, everyone. I'm Rose Gerber, the Director of Patient Advocacy and Education for the Community Oncology Alliance Patient Advocacy Network. Thank you for joining us today. Today, our guest is Dr. Alan Balch, from the Chief Executive Officer of the National Patient Advocate Foundation and the Patient Advocate Foundation. Many of you probably recognize his face. He's a very well-known expert in this area. He's been involved in patient advocacy for many, many years. These are two very highly regarded organizations that many of you are probably familiar with and hopefully have benefited from the multitude of resources that they offer. The topic today is addressing health equity in the healthcare system. And what's really exciting for me about today's conversation is, as many of you know, equity became a very hot topic in recent years. But what's going to be so interesting as we listen into Alan's talk today is that his organization has been working on this topic for many, many years. So it is such a pleasure for me to go ahead and just introduce Alan and thank him for being with us and jump right in. Alan, please, we're all excited to hear from the knowledge that you've obtained over the years. Welcome.
Thank you, Rose, for that kind introduction. So as Rose said, what I'm going to do is run through a little bit about, and we only have 30 minutes, a little bit about what we've done in our evolution in this space as an organization, but pivot, to, I think, a broader view of the health system and where it's heading as well, because I think that's probably where many of you can glean some ideas about where you might want to focus your efforts. But we've really had a concerted effort around health equity and social determinants, well, since our inception, really, but we really carved it out very explicitly starting in 2014. The next slide. So that was sort of what I think of as version one. And for those of you who don't know who Patient Advocate Foundation is and what we do, just a few numbers. We always lead with our impact, what we're doing to help people. We, in 2021, served at about 160,000 patients. And then if you count their entire family, double or triple that number. We have case managers who help patients with all sorts of problems. I'll talk more about that later, but we're able to obtain $22 million in debt relief on behalf of those patients. We have direct financial assistance programs in the form of copay and other financial assistance. And we were able to award $350 million to patients in direct financial assistance. We pride ourselves on a diversity of programs with lots of partners. We have 35 different case management programs and 50 different financial assistance funds. Most of them operated in partnership with other nonprofits, including academic partnerships as well. We even have students on scholarship. So we've got a pretty robust scholarship program that has 30 students on 4-year scholarships, not full scholarships. I wish we could do full scholarships. These are partial scholarships. Next slide. So we're organized as really a direct patient assistance model through case management, copay assistance, and financial assistance. But then we have a variety of programs and services that, our outreach really is how we take that opportunity when we're serving patients to then extend the reach of those services to lots of people. And so community engagement, health services research, patient education. I'm not going to linger here other than, part of our challenge has been how do we take each one of these and have sort of take each program and figure out what can we do from a health equity and diversity inclusion perspective for all of these, not just have a silo of health equity work, but how do you carve out within each program and service, and even within the organization, a health equity focus. Next slide. So like I said, we carved this out purposely starting in 2014. And so I'll just go through quickly what that was in our evolution. It started with us setting some board level goals. Our objective was to really simple, to expand the level at which our current programs at the time were able to reach and serve patients facing inequities in the healthcare system. And we sort of picked two main things we wanted to do to get started was first establish some board goals and metrics that we'd use to hold ourselves accountable, but then also hire an executive leader in this space. Next slide. So again, pretty straightforward. Our first goal, and we've had it for years, we just updated it, really expanding our ability to bring services to specific populations. And we define diversity, at least initially, around diversity from a patient perspective, from a disease perspective, as well as from a racial and ethnic minority perspective. And then we set several indicators and goals that we tracked, including how many patients were we serving, different types of diseases, different racial and ethnic minorities, what types of relationships did we have, with different disease-based groups, as well as different groups that represented racial and ethnic minorities, and then obviously those that combine the two. So there are definitely groups that focus not only on a specific disease, but on a racial and ethnic minority within that disease space. And then how many were we bringing new programs and new relationships and partnerships in both those spaces, the disease diversity as well as the racial and ethnic diversity. Am I coming through okay, Rose? Can you hear me?
Perfect, sound great.
Okay, next slide. And then, of course, many of you hopefully have had a chance to interact with the wonderful Shanta Chambers. She joined PAF in 2014 as our EVP for Health Equity Initiatives and Community Engagement. Again, not necessarily lead a health equity silo, but to really organize and lead our community engagement work, which I'll come back to that because I really think that's the most important framework through which to think about how to reach diverse populations is through a community engagement model. But also to really think about how do we go across the organization and really apply health equity as a principle and a lens through which to look at all of the work we do, as well as how we operate internally. Next slide. So our initial approach was really that one community at a time. And if we've learned anything from sort of sociology and ethnography and even political science, the place really matters. And if you want to reach, racial and ethnic minorities and vulnerable patient populations aren't monolithic. They really, a lot of it depends on where they are, where they live, what community in which they reside. So I would actually think of it as not so much an approach of how to reach certain populations as much as how to reach people in certain communities. And when you think about healthcare, the healthcare system itself is really just a bunch of regional and local entities, right? So all healthcare is local, just like all politics is local. So thinking about how to do this at a community level, I think is really the key. And we've long had this mantra of one patient at a time. We added to that sort of one community at a time. And we literally tried to go into a few communities and really establish some relationships and a presence with particular disease populations, as well as particular racial and ethnic minority populations and the hospital systems that serve them in Memphis, in Houston, in Chicago, in West Virginia. It's hard to scale that though. So that's sort of version 2.0 is about how to scale that, but go ahead, next slide. So it literally brought us into live, this was a challenge during COVID as part of the reason to also pivot to 2.0 was, live events, right? Really being present, creating relationships in the community with the health system and the patients that it serves, doing skilled communication workshops, really helping those groups, the local groups, the community-based organizations understand when and how to link to us and the broader healthcare system safety net. So really trying to connect them to the resources that are really extensions of what's available in the community through national opportunities, whether it's the Medicaid program or our own case management services and financial assistance. Next slide. So as local engagements and then also partnerships with organizations at the local national level, again, that serve specific populations of individuals, and really building and sustaining those relationships over time. Next slide. So these are the types of things we were tracking in addition to how well we're doing serving a diverse patient population. Now, we were fortunately in a place where we have a very racially and ethnically diverse staff. Over 50% of our staff come from a racial and ethnic minority, and then our very racially and ethnically diverse board as well. And so we also track, how are we doing with serving different disease populations as well as different racial and ethnic populations. And these numbers don't happen by accident, right? This is really a reflection of really hard work to go into communities and try to reach people where they are. And they're not underserved by virtue of being a racial and ethnic minority. They're underserved because if they need our help, and they're coming to us, regardless of what your disease is or your racial and ethnic minority status is. If you're coming to us or an organization like ours, you have a problem that's related to social determinants or health inequities. So you're underserved because you're needing our help. So next slide. So, a lot of what that meant was connecting patients to our case management program, which really is a very hands-on, very in-depth, we call it, you might think of it as social needs navigation, we call it case management, but really about reducing financial burden, enrolling patients as needed in appropriate safety net resources, and then helping them, we not pick insurance, but helping them understand and use their insurance, optimize the use of their insurance. Next slide. And so it really is through that program where we really had the most effective reach because it's so personal. and so connected to the individual, where we've had the most opportunity to kind of learn what's happening, what it's like to be an underserved patient, particularly a racial and ethnic minority patient in the world's most complicated and expensive healthcare system. So the general profile of the patients we serve is a very low income. There's no income eligibility test here, but it's the average income is about $20,000 or less. Most of the patients are insured. 40% come from a racial and ethnic minority group. And we actually serve patients now up to over 700 different diseases in our case management program. The bulk of them still are in cancer. Next slide. And really bring this up because it becomes relevant later, like the punchline, like what do you need the healthcare system to be able to do better in order to really address social determinants and be more of a resource to not only racial and ethnic minorities, but any patient that is having, that is experiencing social issues related to health inequities, especially those that are driven by social determinants. So at the end of the day, the types of things we work on in case management are paying for utilities, housing, transportation, nutrition, disability, insurance. It's mostly the non-clinical dimensions of the world. And if you go to the next slide, we really are talking, this is from the Kaiser Family Foundation. I love this slide because it kind of gives you more, kind of breaks down the idea of social determinants into different elements and different dimensions. Because it's not one thing, right? So it's a lot about economic stability. And the ones that are circled here are the things that we overlap with as an organization, particularly our case management work. So there is this opportunity within the healthcare system to address social determinants, especially those that have bearing on a patient's ability to achieve the health outcomes they need and deserve in the healthcare system. So next slide. So we tend to talk about health equity through that lens of social determinants because it does create something that the healthcare system can sink its teeth into, if you will. So we've been sort of transitioning into version 2.0, and this is where I think there's some things, if you're still trying to figure this out yourself, this is a model that we've used to kind of think through what's our next iteration. Next slide. And we really started with the CDC's model. So this is a good way to think and organize how you're approaching your work is, think about how to make it science driven. How do you lean on the science? What's your methodology and process for doing your health equity work? How do you then optimize all your interventions? And that's what I was saying at the beginning. We have all these different programs and services. How do we optimize each one using some methodology so that it really has that ability to address social determinants or health inequities? Really, partnerships is the key then. You're not going to be able to do it alone. Really, community level partnerships, I think, is the ultimate key here, is for reasons I already stated. And then the E here is really make sure you got your house in order. Really, what are you doing internally? Even if you think you're in pretty good shape, in some ways, there's always more you can do. So you also have to think about how to do this work, what you need to do internally. So that's where we started across all these, and I'll go through them very quickly. But if you go to the next slide, we were fortunate to be part of a Robert Wood Johnson Foundation Equity Learning Lab through our relationship with them. It really gave us an opportunity to learn from and partner with other organizations that were going through a similar internal process. Next slide, we created a health equity Infiniti group, and I won't go into detail, but basically lots of internal representation in meetings and mapping of our own, where we could do better, setting goals for ourselves internally across a range of different dimensions. Happy to share this work if anybody is looking for some model to use. We didn't come up with it ourselves. We, again, used the framework that the Health Equity Learning Labs that Robert Wood Johnson Foundation provided as a guide. Next slide. So again, getting back to the optimizing interventions, I think that starts with what's the science you're going to use to figure out how to do that. So, we wanted to, through all of our programs, figure out what's our health equity, what's our social determinants approach across all of our programs and services, even those that are already geared towards that to begin with. Because again, the real goal here is how do you if we wait for people to come across our doorstep, it's important, they need help. That's why they're coming to us. But the goal is to reach those that aren't coming across the doorstep, right? So same thing with clinical trials. If we're waiting people to come to the clinical trials, you get people who need the clinical trial, but the goal is you really have to go out into the places where people aren't being served, and aren't reaching you to help them find you. And that means not showing up at their doorstep, but really working through the trusted entities and the organizations that are the trusted organizations within those communities. That's hard to scale. Next slide. So what we started with that C, right? The health equity science. What's our methodology, so to speak? And I'll go through this quickly because you may have figured yours out. We used, go to the next slide. We ended up using the social vulnerability index, which really helped us figure out what community. We continue to live in that model of the key is really community engagement and one community at a time. But how to use a methodology to figure out how to scale that, and where do you find a broad suite of communities that you really need to be present in and collaborate with, rather than one at a time. So we've sort of used that community engagement, like where do we need to be, in what community should we be reaching out to and creating more partnerships in. And that's where we use the science of the SVI, next slide, to help us figure that out. So the CDC really, through the diabetes division, launched this new mapping system where they took the SVI, which has been around the CDC for a while, and really encouraged the use of that to align that, to cross-reference the SVI with chronic disease burden data, with surveillance data, to figure out where is that combination of vulnerable patient populations and burden of chronic disease, to try to figure out, and this is county level data, and I'm an old geographer by training, and I know there's limitations to do it at the county level, but it has its benefits, right? You have to be a little more sophisticated in that, but starting at the county level is a good place to start. So we took up the call from the CDC to really use this as a tool to help better align our resources to address the needs of people at risk. Next slide. So a quick tutorial on the SVI for those of you who don't know it, and the reason we like it is because it takes a broad view of social vulnerability. It's not just defining it based on one dimension, like disease diversity or racial and ethnic diversity, but it really reflects 4 different domains, 15 different variables. And again, I brought up the case management work at the beginning because it also reflects the types of issues and problems we see routinely in our case management population. So it's actually a good reflection of who we are and the work we've been doing, not just for the last 8 years, but 25 years in case management. So that's why this was a good fit for us. And our board really challenged us in our sort of version 2.0 to think broadly about diversity and inclusion, not just from one dimension, but from a variety of different perspectives. So there's several things like this. The deprivation index is another one. But if anybody wants to talk offline about the SVI, strengths and weaknesses, happy to do that. Next slide. So we really took that idea and we created our own chronic disease burden index, because we're not just one disease, we're a lot of different diseases. And I won't bore you with the details, but we came up with an index using CDC data and cut points that had 17 different variables. And we use those now to sort of, from a methodological perspective, we combine our chronic disease burden index and our social vulnerability index to try to figure out where we should be for certain programs. And we applied this first in our copay program. And I'll just show you quickly what it looked like, and then I'll pivot to sort of this broader perspective of where the healthcare system is going. Next slide. So this is the SVI. So the brighter the color, the more socially vulnerable. It's a relative scale on a 0 to 1. So it ranks each county relative to each other in terms of social vulnerability. You see a concentration really in the Southeast and Southwest. The urban spot, the urban locations with high population density are typically smaller on the maps. They're harder to see. Places like Cook County and Bronx and Philadelphia, et cetera, Wayne County and Detroit. So we use this as sort of the starting point, and then we go to the next slide. You kind of cross-reference that against chronic disease burden, and you get a map like this. When we thought about where should we focus our copay efforts from a health equity perspective, this is the map that we created when we did that cross-referencing. So next slide. So we ended up launching about 10 different what we call health equity funds that have, in addition to our general funds, that are really targeted to the zip codes of these counties. And then of course we'll wrap around, because it's not enough to just build it and they will come. You actually have to go out and build relationships with the community organizations on the ground to help them become aware of this ability to get financial support for patients in that zip code, in that county, who really need the help. Next slide. So at the end of the day, though, and this is where I'm pivoting now awkwardly to this bigger picture, I think the challenge we have is, and this is what we're trying to do, is figure out how to internalize within our own systems and processes this thinking around social determinants and how to better reach those who need the type of help we provide. And I think the healthcare system as a whole faces that same challenge. So this is a bit of a heuristic here, and this is overly simplistic, I apologize. But generally speaking, the healthcare system has long sort of done a really good job of handling the clinical dimensions of care, right? Treatment goals, clinical goals, medical side effects, direct medical costs, and everything that happened outside the four walls of the clinic was kind of, well, what can we do, right? So that was all out of scope. And so I think the challenge now, if you go to the next slide, you go back to that Kaiser Family Foundation mapping of social determinants. Next slide. Yeah. These are, again, the things that I think are not only actionable within the healthcare system, but you can't ignore them. If you ignore them, they will eventually rear their ugly head for many, many patients. So you can't just say it's not our issue anymore. What can we do? Because whether you want to or not, these problems are going to get in the way of many patients' ability to achieve their health outcomes. So better to kind of figure out how to deal with this and how to internalize it within the healthcare system. So next slide. So again, you have all these social determinants. I listed the ones that we feel are really important, that we see routinely. You may have others, and the intensities depend on a lot of factors, but these are generally the types of things that the healthcare system really has to be able to figure out and address as part of a patient's healthcare decision-making, care planning, and then as they move through the care continuum. And these are challenging issues. This is not easy to do. And I'll tell you, I'll linger a little bit here on the way that the healthcare system is starting to internalize these. And there's risk to it. But next slide, it's the ZCode system. And I don't know how many of you have heard about this or are aware of it. And then everybody knows what ICD-10 codes are, and soon to be 11 codes. But it's basically that concept of the ability to establish a diagnosis for a problem. And so there is this ZCode set. It's a 10 code set that really is there specifically to address social determinants. But of course, as you know, in any healthcare system, when you can't diagnose without screening. So if you're going to have a diagnostic system around social determinants, you've got to be able to screen for those. You have to have the cut points to be able to make the diagnosis. And ultimately, once you diagnose something, you have an obligation to treat. So then what's the intervention? So I think if the ZCode thing really takes hold, I think and you're starting to see a lot of more screening around social determinants in the environment, particularly not just at the healthcare system, the practice level, but also within the insurance plan level and the retail pharmacy level. So I think, so you're seeing more screening. You've got this diagnostic code set out there that's being developed. And ultimately there's going to have to be, a really robust intervention and probably some reimbursement for that intervention ultimately against this problem set. So next slide. So these are the Z codes at the 2-digit level, right? So things about education and literacy, employment, unemployment, exposure to risk factors, housing and economic circumstances, upbringing, family circumstances, psychosocial circumstances. So go to the next slide.
Alan, may I just ask a question for the benefit of our listeners?
Sure.
So the ICD code, that might be familiar to people that work in billing, but can you explain, is this part of a patient intake form? Because a lot of our audience is patients and survivors. So if you could take a step back and explain
it's not, everybody's doing this a little bit differently. So right now there's some institutions are sort of just documenting this or asking questions, usually from a prepare tool, a social determinant screening, and then assigning a Z code to a patient. It's not being used the way a medical diagnosis would at this point. It's more for just collection of data. And I'm not going to go through this slide, but this kind of speaks to the different ways people are using it now. So I think right now we're really at step 1 and 2 for those that are using it. And this is a whole longer conversation that we could, so I'm not going to go through all this. Yeah, but I think a lot of places are at step 1 and step 2, just collecting data and then tying it and documenting. So it does create an ability to a taxonomy system, if you will. And now we have our own coding system in case management. We actually have about 165 codes we use for different problems. They map pretty well to the Z codes, but I put this out there just for people to start to pay attention to, because I think it is an attempt, and I think it's a worthy one to start to internalize into systems that are already established, a way to kind of bring social determinants into the world of healthcare. There's risk here. So I'll end on that note, but go ahead. The next slide, please. So this hasn't happened yet, but there's efforts to try to expand these Z codes, build them out to the 100th level, which is more typical, right? So, cancer ICD-10 codes, they're down to pretty minute granular levels of specificity. Same thing here, really trying to get down to specific levels of types of, in this case, the Z59, housing and economic circumstances, you can start to map these down to food insecurity, right? Paying for utility. And now remember when I showed you long ago, the top needs that we see in case management, you start to see these showing up, right? The inability to pay for utilities, for medical care, for transportation, adequate clothing. So the idea is to get fairly granular, because then the intervention, how you screen for these things and how you intervene for them, and how they manifest themselves in patients' lives are all very different. Next slide. I hope this isn't too boring, but like I said,
it's very interesting.
Once you start to marry, and I don't have time to go through all the screening, but once you start to marry the ability to screen, which we're seeing, the ability to diagnose, like on par with how we medically diagnose things, the next step is intervention. And I think that's the challenge here. And what patients say they want the most at the end of the day is they don't want to just know about their problems. They want to know what's going to be available to help them with their problems. So we have to bring some common intervention set to bear against the screening and diagnostic activity. And for us, that's social needs navigation. So that's really when we think about what's the ultimate, it's not the ultimate solution. It's something the healthcare system can do writ large to not just screen and diagnose, but to actually bring intervention to scale against the types of problems we're talking about here. And so it comes back to that case management model, not necessarily ours, but some version of that where you really are connecting, because most of the help and the resources for these issues are going to be out. You can diagnose them and screen for them within the context of healthcare system, and they have relevance to the patient's journey in the healthcare system. But most of the solutions are really linking patients to resources outside the health system. So social needs navigation really is that intervention that sits at the intersection of the community resources and the healthcare system to help connect the gap between those two things, to connect patients to the resources in their community beyond that can help them with these issues. So next, there's a whole bunch of slides here around social needs navigation that I won't go through because I think you get the idea that, if you really want to address social needs, if you're going to really screen and diagnose for them, social needs navigation is the intervention. But the final point I want to make here is it's really important not to think about these things as just something we do like to treat side effects. Like it's not enough to just think about this as something we do and screen for like a medical side effect. We really need to put these in the context. If we're really going to address social needs and have this social needs navigation model, if you go to the next slide, what we're really talking about is a system. You can go skip one more. We're really talking about one more. Trying to wrap up here. Yeah, we're talking about a model of care, right? Where we start to introduce and have these conversations about social determinants at the point of shared early on in the process when we're starting to do shared decision making as well as care plan. It's not enough to wait until these things have been decided and then start to worry about social determinants, just like we worry about other side effects. We really need to think about how to introduce and start to have these conversations in a trustful way before we start screening and diagnosing people. Because I think and here's the rub, the healthcare system is really good about doing things to people. It's not so good about doing things with and for people. And I think that's the challenge here for this particular set of issues. It really is critical that we figure out how to do this in a way that we're doing it with people, not to them. So if screening for ZCodes and diagnosing them becomes just like another medical diagnosis and intervention, that could actually build distrust. It could actually alienate people because these are really sensitive issues about people's upbringing, about their home life situation. Right. If you don't start to incorporate these conversations and build trust around them and help people understand the reasons why these things are relevant to their clinical journey, this process can be over medicalized and actually become very alienating. And at the end, so that's really the emphasis here is this is not something we wait and do as part of sort of patient management or care management. It's something that we do and start to introduce and talk about these issues early on as part of decision-making and care planning. And the last point I'll make, what patients ultimately want, go to the next slide, is a process where they feel respected, listened to, and there's a personal connection, particularly around these types of issues that are related to health inequities and social determinants. And the last slide is the ultimate goal here is to build trust, right? If we don't use this as an opportunity to build trust, right, both within the individual patient as well as within their communities, that's really where we're going to be most successful in being able to address this as a whole. So that's where I'll end at 12:30. That's the last slide too. You can go to it.
Thank you so much. This is, really great information. I think you've really showed how this is not a topic that's just a couple of buzzwords. It's really in-depth information. I mean, I'm personally fascinated by the Social Vulnerability Index. That was something I had never heard of, so it's very interesting to me. We have a couple of just quick questions in the chat if you want
Sure.
to, let me take a look at them. Thank you for everyone who's wrote some nice comments to Dr. Brock. We appreciate it. So there's a comment about just acknowledging that there's no reimbursement when utilizing ZCodes. Are they used both in commercial and Medicare?
There's no reimbursement yet, and it's really up to whoever. Like right now, the ZCodes are sort of at will. Like institutions are using them. I've done a couple webinars with hospital systems where they talked about how they're using them. I think those are recorded. I can send a summary if you want, or people can look that up. But they're at this point really being more used to document, as sort of gathering the data and documenting it. There's really not anything being done with the data yet in a ZCode sense. There are definitely people that are in organizations, institutions that are collecting social determinants data and intervening against it and doing work against it, just not using that model, the ZCode, and a reimbursement model. So I think also there's a lot of work happening around social determinants and intervention. There's this ZCode, train that's kind of going down the tracks. I think ultimately those things will start to marry as this health system really starts to internalize this whole concept of what can we do and how do we organize ourselves to be able to document, to screen for, to diagnose, and then intervene against social determinants. And it's a great opportunity, but I also think done wrong, it can really do a lot. It could actually do more harm than good. And I think that's our first, let's not do harm. So let's be thought, and that's why I bring it up. I think it's really important that all stakeholders get together and think about how to build this system the right way so that ultimately it builds trust, it builds respect, it builds the capability to listen to and not just medicalize a problem and try to treat and do something to the patient, but do that with them and for them and in partnership with them.
Something called shared decision-making, right?
that's why pulling this into early and often into that process is key. It's not a pop quiz. It's not something you wait and introduce.
Right.
It's something you've got to socialize people to early and often and make them understand why their care team cares about this for them. They're not trying to ration care. They're not trying to treat anybody differently. And that's the fear that people have is when people start asking about their financial situation or their housing situation, that somehow their care is going to be rationed or they're going to be treated differently. So we have to be careful about how we should internalize this problem set, but how we do it is going to be really important and doing it in a way, again, that builds trust and that also focuses on the community aspect of this is going to be really important. And that's much hard. I wish I had the secret for how to do that, but I've given you some sense of how we're thinking about it, at least.
Thank you. And I want to encourage everybody to visit your website. There's two websites, National Patient Advocate Foundation and Patient Advocate Foundation. You really do have a terrific website. Everything is very easy to follow. There's great content on there. Just a reminder to everyone, because I know we get asked about slides being available. This, even more than slides, is we have this entire recording that goes up on COA's YouTube page. Oftentimes we do have it on Facebook Live. Sometimes we have a little bit of issues with Facebook, but this information is out there. And I want to, speaking of the website, there's a quote on the website that says, NPF is here to ensure that the patient perspective is heard and that it matters. And that quote comes from Dr. Brock. And I appreciate that because as patients, we do want our voices to be heard, but a lot of times we don't have the power or the authority. And that literally comes from the top. And you've done a terrific job today. Thank you so much for sharing your knowledge with us. And again, thank you to all our participants and enjoy the rest of your day. I have one more slide before we sign off. Thank you, Dr. Brock. We appreciate it. Next slide, please. You're not a slide, but I meant let's go to the next slide.
No problem. Sorry to run a little over time.
No, not at all. You're great. So next month is National Clinical Trials Month, and we'll bring you back here to talk about the exciting things going on in the clinical trial front. Thank you, everyone, and enjoy the rest of your day.
Thank you.